First of all, what are geroprotectors? Geroprotectors are drugs or supplements that interfere with the process of cellular aging. So there are processes that are conserved in all cells and really are important for the maintenance, proliferation of cells. And these are processes of mitochondrial function for the production of energy of the cells, DNA damage repair for genomic integrity, autophagy for eliminating damaged proteins and also damaged mitochondria and so on. And telomere shortening, obviously very important during proliferation. And what happens with cellular aging is that these properties become dysfunctional, and this is independent from which cell type they're in. And so with the mitochondrial dysfunction, you have an increase, for example, in the production of reactive oxygen species. And while small amounts of ROS are really important to activate the DNA damage machinery, and therefore they're actually positive, high amount of ROS induce DNA damage. And at the same time, the DNA damage machinery that is supposed to repair DNA is actually downregulated. So have a double whammy there. And at the same time as well, because autophagy is working less well, that means that not only you have a damaged protein hanging around, but also you don't have, the removal of damaged mitochondria is slower. So you have more damaged mitochondria hanging around, amplifying this process. And so the cells get to a point where it accumulates a lot of DNA damage, or telomere become extremely short, and what does it it signals to become senescent. Just for a point of interest here, I will talk about supplements and drugs, but actually, for example, calorie restriction interact exactly where you see CR, so interact at mitochondria level, at autophagy, and also in the process of ubiquitination. So all of these, you can have different approaches to actually limit the amount of senescent cells hanging around. So what is senescence? Senescence is a cell cycle arrest and secretion, so the cells stop doing the specific function they may do. You know, for a muscle cell, it could be a contraction, and for neuron cells, it is signaling, but they stop doing that, but they're still alive and secrete a lot of pro-inflammatory factor and tissue remodeling factors, so metalloproteinases. And what this does two things. It sort of induces senescence in the surrounding cells, and also changes the way tissue regeneration works. So senescence is actually useful in a young age. So it's a transient phenomenon and happens in moments of regeneration. So for example, wound healing. You don't have wound healing if you don't have senescent cells. And this is because what they do, they actually attract through the SASP, they attract immune cells. And these immune cells clear the debris and then activate the stem cells to actually start regeneration. But what happens, but they usually are transient, so they just come in and go out. And we don't really understand why that is. We think that the immune system actually cleared them off, but we are not sure. But what happens is that with age, they actually remain in tissues, and they increase in number across tissues, and this persistent chronic inflammation sort of tip the balance between regeneration and fibrosis and impact the function of multiple tissues. And so it has been shown that if you eliminate senescent cells, and now we know we can do this genetically, but also with drugs and supplements, what happens is that you improve a number of conditions that you can see here and more. And so for this reason, sort of senescent cells seems to be really central to when we want to target multiple diseases at the same time or multiple deficits. So for this reason, we propose that really what senolytics or senotherapeutics, so the drugs that actually eliminate senescent cells or prevent their formation, can be good for frailty and multimorbidity. So, there are people in the audience that know frailty much better than I do, but the way we define it is accumulation of deficits across organ system, which lead to an impaired ability to respond to an adverse event. So If you're young, your tissues functioning, your organs are functioning really well. You have a lot of spare capacity. If you have a stressor, for example, an infection, you will be unwell, but you will recover fast back to baseline. If you are older, pre-frail or frail, your spare capacity is very much reduced. And therefore, if you have a stressor, you will not be able to respond as effectively. You will probably be losing your independence. You will be dependent, and it will take you a long time to recover. And most of the time, you don't go back to baseline. And that may mean that you may need for, social care and support. And this is a really big problem in terms of numbers and also in terms of cost. The cost, for example, of social care in the UK for someone with frailty compared to someone without frailty of the same age is 10 times higher. For multimorbidity, this is the presence of 2 or more chronic conditions. And while in medicine, the model is to study one tissue at a time, we are all experts either in heart, bone, or whatever. The reality is that patients experience this together. More than 50% of those aged over 65 have more than 2 chronic conditions. And this is really a leading cause of service use. But what we actually know is that those diseases are not separate. We study them separate, but actually they are quite, they're supported by a number of common pathway and genes. So this is, for example, is the diseasosome. How is it called? But every dot is how many genes there are in common to other disease in each pathology, and this is the link of the number of genes in common between these 2 pathologies. And so you can see there is quite a variety of them. Some you would expect them more than others. But what this suggests is that actually a better approach would be a system approach where we target the underpinning pathway of the group of disease together. And what we really want to propose is that senescence may be one of these pathways. So what we have been doing, so I was leading a European program called Mouse Age, a very unfortunate name, but that tells you when we started, where we started. We were concentrating on thinking about which experiment we had to do in mice. And what we have realized that the real barrier to clinical translations was actually the regulatory framework, the fact that frailty is not a disease and therefore cannot be, any drug cannot be registered, and so that you cannot actually sell the drugs. That means that pharmaceutical companies are not interested. The fact that most of these drugs are actually mostly preventive. They may work at very early stages of disease, but that means that they imply longer trial and quite costly and sometimes unfeasible. And also, if you treat patients later on, when they already have signs of frailty, these patients are usually excluded from clinical trial. And therefore, there is little experience of how we actually do trials with these patients. And so we brought together experts across Europe from 25 countries and outside also in the EU, so in the US there is the Translational Geroscience Network, to really try to think about how we would take this, how we would overcome those barriers. And we had discussion with the MHRA and the EMA, so the regulatory bodies, and really the advice was to focus on 2 or 3 case studies, try to think about a trial of short duration and use repurposed drugs or supplements to start with to really avoid problem of safety in the first place. So what I'm going to do in the next few slides is really show you some of the 2 case studies that we are developing. One is with the drugs and another one is with the supplements. And then, it's primarily preclinical work. But then at the end, I'm going to sort of tell you how we are thinking about the project, the trial design. So the first drug is a nitrogen-containing bisphosphonates and is used for the treatment of osteoporosis, inhibits bone resorption, basically prevents fractures. Some of you may use this drug with your patients. The reason why we got interested was because it's given once a year, so from a prevention point of view, it's easier to administer, and it's a little bit similar to a vaccine. And also because we had the way it started is really from this graph here, where it showed a dramatic increase in survival of patients on zoledronate compared to placebo. These are postmenopausal women taking zoledronate. And so also there was further study that showed that these patients had a reduction in death due to pneumonia and cardiovascular events, not actually a reduction in the incidence of those diseases, but a reduction in death. And that suggested to us that there was, perhaps an effect on resilience. And indeed, this further study showed that patients that were on bisphosphonates, so this is not only zoledronate, but also alendronate and rezidronate, they were going to ICU for causes that were unrelated to the skeletal effects. They had a much better survival and they stayed less in hospital despite having a higher comorbidity index and being older. So so the first question we asked was whether zoledronate was a new geroprotector, and I showed this data for those of you that were in the talk on Tuesday. But in essence, zoledronate did reduce accumulation of DNA damage and delay senescence, which, as I showed you, are important hallmarks of aging, and also interfered with aging pathway like the mTOR and require FOXO3A, which has been associated with, for example, long life in centenarian. And then we showed also the extended lifespan in Drosophila and delayed the onset of couple of sort of organ dysfunction in Drosophila, which is intestinal dysplasia and climbing ability as a muscle loss phenotype. So we felt like we were ready to go and test these drugs in mice, and this is our pipeline. We started at middle age, so this is 12 months of age is about 50, equivalent of 50 years old. Before starting the intervention, we did a panel of tests. Frailty index, this is similar to, equivalent to the Rockford frailty index. It sort of captures 31 different parameters. But we had also test of cognition, novel object recognition, muscle function, hanging bar and rotarod, metabolic function, glucose tolerance and insulin tolerance, and echocardiography for cardiac function. These were repeated at 18 months, which is the time point where mice start showing some signs of dysfunction. And then, frailty index was done across the time, every month, to look at the trajectory, and the assays were repeated just before culling. So the first question we ask is whether it does reduce senescent cell burden, and the answer is yes, it does. So we have examined this at the moment in the visceral fat, and this is where most senescent cells actually accumulate. At the moment, we are looking at all the different tissues with a panel of different markers, but in essence, it does the job that it's supposed to do. And then what about frailty? So this is the trajectory of 20 mice, and you can see that already from 18 months of age, the mice that have been treated with ZOL have a lower level of frailty than the mice treated with PBS. It seems like the curves start opening here. In a way, in retrospect, I wish we kept going for a bit longer, but it is also true that due to welfare regulation, we cannot get a mouse extremely frail. And so it's just about reached 0.3. We could have probably got to 0.4, but not more than that. That is definitely a limitation of mouse studies. One of the biggest signs of frailty is loss of muscle function. So we look at hanging bars. So basically, you take a mouse and you're hanging on a wire, and you see how long it can hang there. And they usually are afraid to fall, so they hang for dear life. And so you can see that with age, so this is 10 months and this is the 22 months, you can see that there is a drop in the time they manage to hang on, but zoledronate doesn't do very much. However, rotarod, so this is a mouse staying on a rotating platform. So these require muscle strength, but also require balance and coordination to do that. And you can measure how long it's able to stay on this rotating platform. And again, you can see that with age, there's a drop in the time they can stay on, but zoledronate brings them back. So that suggests that zoledronate may not have a direct action on the muscle per se, but on the neuromuscular function. But long-term memory, so we tested for short and long-term memory. So basically the way you do this, you put a mouse in an arena with 2 objects, and then you let them know the object for a little while, then you take them off for a different period of time, 3-4 hours for short-term memory, 24 hours for long-term memory. And then when you put them back with one object is the same and the other object is a different object. And if they recognize that it's a different object from the one they saw the day before, then they stay and explore it for longer. They're more interested into it. And so by counting how much time, we can see whether they did remember or not the object. And so you can see that with short-term memory, actually, there is no difference between young and old. They seem to retain short-term memory, and so later it doesn't do very much. However, for long-term memory, at baseline, there's a significant difference between the known object and the novel object, but with age at 18 months, this difference is abrogated, is not significant, and zoledronate seems to improve this timing. So we think there is an improvement in long-term memory. We also looked at glucose tolerance and cardiac ejection fraction, but we didn't see any difference. But it's also true that mice do not develop insulin resistance unless they are meant to, there is a model for it, but not spontaneously. And similarly, they don't really develop a lot of cardiac function, so you need a specific model. So we don't know here whether it doesn't do anything or whether we need to have some damage for zoledronate to actually work. So in conclusion here, zoledronate fulfills the definition of a geroprotectors and delays frailty, retains neuromuscular function, long-term memory, but we do not see any effect on cardiovascular function and glucose tolerance. And so we need to do a little bit more work to understand whether, in specific model, this may be the case. So the second one I want to talk to you about is physating, and we have started using physating in a model of multimorbidity, which I'm going to describe in a second, but then we also did some work on frailty. So physating is a flavonoid, and it is an antioxidant, and is present in several fruits at low concentration. The highest it is strawberry. It's about 160 micrograms per kg. So, and we dose the mice as 500 milligrams. So you can see that we would need a huge amount of strawberry to have any effect. It has been described with a variety of properties, anti-inflammatory, anti-proliferative, obviously antioxidant, but really in recent years has been demonstrated that it's a senolytic, so it kills senescent cells. And this is really interesting because if you kill senescent cells, it means that you don't have to give it every day because you give it for a couple of days, 3 days, a week, you kill your senescent cells, and then you wait for them to reform. And so it's not something that you have to give all the time. And at the moment, because of this, it seems to be quite safe. There is several clinical trials ongoing to really test the safety in older people. They are primarily, I have to say, in the US. So, as I said to you in the first slides, we think that disease at the end of the day are not in isolation, and they are actually connected. And nobody will just sort of dispute that there is a association between atherosclerosis or cardiovascular disease and dementia. But whether this is an association or really there is a causal link, that's what wasn't known. And so my colleague Sheila Francis and with his very good postdoc, Osman Shabir, they have induced atherosclerosis in wild-type mice through using adenovirus with PCSK9 receptors. So this is basically block the LDL receptors and allow increase of LDL in mice. And you can see here that they form nicely atherosclerotic plaque, and you can see them here. But then she asked the question, what changes in the brain when we induce atherosclerosis? And you can see here there is activation of microglia. There is a reduction in the number of neurons. There is a reduction, as you would probably expect, in perfusion of vessels, and there is an increase in inflammation in the brain. And when she did this with a model of dementia, so the J20 model, which is quite a mild model, what she sees is that induction of atherosclerosis increased the number of AB plaque in the hippocampus. So suggesting that sort of it boosts, so accelerate at the very least, the dementia phenotype. And so what we asked here was, so what happens if we actually induce atherosclerosis in old mice and then we treat them with fisating? And so we treat them with 2 weeks on, 2 weeks off. We don't really know whether that is the best regimen. We probably could have got away with less, but we went on the safe side. And we just confirmed that you find a reduction in markers of senescence in liver and brain, and then we went on to see what happens in the brain and in the vessels. So you can see that there is a reduction in atherosclerotic plaque, and this is, so we went back and looked at what was happening in mice that received, for example, atorvastatin, and this is very similar actually. So it's produced a similar change, and that is not given it every day, so that there is already an advantage there. In the brain, we did not see an improvement in the neurons or in the astrocytes, but we did see a reduction in the astrocyte activation that I showed you at the start, and that is considered one of the initial signs of a dementia. And so we are now moving on into the dementia model to actually see whether we can reduce the number of plaque. But since we were at it, we also measure frailty, and we saw that we have a reduction in frailty index, and we have an improvement in muscle function, so both hanging bar and rotarod. And actually, the reduction that we see is better than the one that we see with zoledronate. And although it doesn't seem very much, if we look at the paper from Rockwood, for example, he recognized that the meaningful clinical difference should be about 0.03 of his frailty index, because that corresponds to 1 point in the clinical frailty scale. So that could be a difference between a patient managing well to a patient that becomes vulnerable. So that means that, if we were to translate the finding in mice in people, that would make a beneficial effect. So, we have a long way to go, especially in the multimorbidity model, to define the preclinical side, obviously in the model of dementia, and also there is a question how far in the development of dementia we can go, and before we don't have any further effects. So how much prevention, how much preventive do we need to be? Because this has an impact in trying to decide which patients we should treat. Because in reality, only 10-20% of patients with risk for cardiovascular disease really develop dementia. And it takes a long time for this to happen, between 6 to 10 years or more. And therefore, obviously, a clinical trial cannot last this long. And so what we need to understand is, can we do it, can you start doing it in 2 diseases separate, so one for cardiovascular and the other one for dementia, and maybe starting for dementia with a mild cognitive impairment, or do we need to develop biomarkers that we can identify in advance those are at risk of dementia, and then also surrogate biomarkers that can allow us to know whether the drugs works very early on. The advice here is that we should try to have some level understanding whether it works or not in between 12 and 18 months. So we have a long way to go here. But where we think we are actually very close to testing patients is with frailty. And in particular, we think that there is a case where, for example, in a case of elective surgery, where this could be really good case study to learn about how to run this clinical trial. Because with elective surgery, we know it's happening. And surgery should be a stressor, so that should sort of catalyze a much faster progression. And also with surgery, particularly for breast cancer or for cancer, you have a biopsy, a diagnosis, and and then you have the surgery. So you have the opportunity to have tissue where you can actually assess level of senescence, because level of senescence in blood is not particularly reliable, so you need tissue, and that is quite a burden for the patient. So we were very lucky that Linda led a study which is called the Age Gap Study, and this is a cohort of 3,400 women over the age of 70 with breast cancer. And that they receive, so the way it goes is that there is a biopsy, and then there is a diagnosis, and 4 weeks later they have the surgery. And she monitored these women for 24 months and actually have a lovely tissue bank. So here what we did, thanks to all the different data that she collected, we were able to calculate the frailty index. And we were able to divide the patient in robust, pre-frail, and frail, and then see what happened to the activity of daily living of these patients at baseline, and then 6 weeks, 6 months, and up to 24 months after surgery. And as you can see here, in the robust, women have at baseline, they're well. They don't have any limitation. After surgery, a small proportion of them, about 20 to 30%, develop some limitation, which partly recover, but not completely. I think the most interesting group is the pre-frail, because most of these women are actually well before surgery. But already 6 weeks after surgery, they have acquired some limitation, different degrees, in more than 60, 70%. So it's really quite profound. And don't really recover in the next 24 months. Of course, when they are frail, they already started a lot of limitation, and the surgery makes that worse. So the idea here is that we think this is a good cohort because we can see already something at 6 weeks. And the idea would be to have biopsy, measure the number of senescent cells, give fisating for a couple of days, and then 4 weeks later having the surgery, and then monitor for activity of daily living. And what we really hope is going to happen is that we see this black bar here going up, and so they really do not develop limitation, because what fisating is doing is eliminating senescent cells and allowing the regeneration of tissue, generating the spare capacity required. So in conclusion, fisating reduces atherosclerotic plaque formation and activation of microglia in the brain in a mixed model. It reduces frailty and improves muscle function. We think that pre-frail older patients undergoing surgery is a really good case study for first in men, and that we would really learn a lot in terms of developing also markers as primary measure of outcomes, because at the moment it's really not clear what we should be using, and so we will try to use as many measurements as possible to see which one is most suitable to detect a change. And finally, I would like to thank the people that actually done the work. So Alex and Jeremy has done all the mouse work. Julia is doing the senescent work. And as I said, Olivia has done the work in breast cancer women. And now she's looking at senescence in those group of women to see whether we can find a correlation between frailty and senescence in patients. And of course, our collaborators. Thank you very much.